truly distinguished panelists today who have extensive on-the-ground experience addressing not only the COVID-19 pandemic, but a range of health issues associated with humanitarian crises in the Middle East, North Africa region. Over the last 1.5 years, we have learned that this pandemic has impacted each country differently, and also each country has responded differently. Countries such as Syria, Somalia, Yemen have gone through a range of humanitarian crises long before the arrival of the COVID-19 pandemic. Our panelists today will help us understand how countries struggling with multiple humanitarian crises have responded to the COVID-19 pandemic. Currently, Middle East is going through an escalation of violence between Israel and Palestine. This has led to deaths and injuries and massive displacements of tens of thousands of Palestinians. It would also certainly lead to a growing mortality and morbidity due to COVID-19, as it will reduce Palestinians' access to vaccinations and their ability to adhere to public health prevention measures. Before I hand it over to Dr. Naser to tell us about the impact of COVID-19 in Syria, especially in the Northwest region, which is not under government control, I'd like to ask Dr. Leslie Gross-Wyrtzen to share her thoughts with us on this growing conflict in Palestine and the impact it could be taking on COVID-19. Leslie, I'll hand it over to you.
Thank you. I appreciate that, Dr. Khoshnood, and I'm pleased to be able to speak to you just for a moment to build on what Dr. Khoshnood was saying about this contemporary moment and in Palestine. And so I just wanted to give some context for what is happening or what has been happening in regards to COVID in the Palestinian occupied territories. So COVID-19 has actually had a really significant impact on Palestinian people. By the end of April, while Israel had vaccinated most of its settler population, only 5% of Palestinians in the occupied territories had been able to access the vaccine. And the new variants that are circulating have really increased infection rates in the territories in recent weeks, in part due to these low vaccination rates, as I said, the spread of variants, and then just the population density, particularly in Gaza. And so in early May, in response to, on May 10th, Israel began aerial bombardment campaign that has resulted thus far in the deaths of 230 Palestinians, including 65 children. And among them, there have been several physicians, including Dr. Ayman Abu Ouf, who's head of internal medicine and head of the COVID response team at Al-Shifa Hospital. So the destruction of residences, roads and infrastructure, and the displacement of 75,000 people, in addition to the bombardment of 4 hospitals and 19 medical facilities, is exacerbating this problem of COVID-19 in the Palestinian territory. And so we're mindful of this humanitarian crisis that is unfolding and intensifying as we talk about the impact of COVID-19 and efforts to address it in other humanitarian contexts in the Middle East and North Africa.
Thank you so much for those thoughts. I'm going to now turn it over to Dr. Naser Almhawish, who's a surveillance coordinator for Assistant Coordination Unit, a non-governmental organization in Turkey. Dr. Naser is a medical doctor with extensive experience from Syria, with an extensive experience in surveillance system. And he's been working in northwest of Syria with the term of team, who's been the team lead of the surveillance team, looking at COVID and other infectious diseases in that region. In 2017, he led the surveillance team, which detected vaccine-derived poliovirus outbreak in northern part of Syria. Dr. Naser, I'll hand it over to you.
Thank you, Professor Khoshnood, and thanks for the Council for giving us the opportunity to talk about the situation that we're going through that was exacerbated by the COVID situation. I'll just walk you through a little bit about political and geopolitical situation in northern Syria specifically, and Syria in general. And it's been a decade since the start of the demonstrations in 2011 in Syria by some civilians, and then that was escalating rapidly to develop into an armed conflict, a civil war, and then everyone started to pour into this country. And the changes of the controlling forces was incredible, was fast, and it led to a full destruction of the infrastructure, health and non-health related also. Then the rise of ISIS and some extremists in the area, where they reached a time where they controlled almost 33% of the whole country, and all those changes led to massive number of displacement for the population. More than 6.5 million are refugees in neighboring countries in Europe and other areas, and almost half of the remaining population of Syria, which counted almost 24 million before 2011, are internally displaced. The majority of them, unfortunately, now are resident in northwest Syria, in this region, an area where 4.5 million are resident at the moment, but out of those, we have half of them as an IDPs, and more than 1.2 million of them are resident in camps in one small portion of that place. The current picture of the field shows that, and of course, none of us would like to see this, but unfortunately, we have 3 controlling forces in the field. The area is controlled by the central government from Damascus, colored here in red. The areas in northeast, controlled by the self-administration, supported by the International Coalition Against Terror, led by the United States. And in northwest Syria, where we have areas with Turkish influence more than other places, in addition to one isolated area, part of the northeast, with a peace spring at the Turkish side, with also a Turkish authority for it, and no access to humanitarian aid, nor a cross line, nor proper cross border, as it is not included in the UN resolution in that place. So looking at this picture and the changes of the controlling forces, it makes it difficult for any humanitarian agency to coordinate with all controlling partners in it, and to have one unified approach to any kind of outbreaks or pandemics or epidemics in this area, which makes it even harder for anyone to deal with. For the program that we are working on with EWARN, we work as a non-governmental organization, and usually this program is something that's run by the Ministry of Health, but the absence of any kind of governance in the non-governmental health areas necessitated the establishment of this program in 2013. And another thing is that we are non-professionals at that time, and we learned by doing. I'm a general surgeon as a background, but I had to shift my career towards surveillance and epidemiology. We cover all northern Syria, but with COVID, and because of the different controlling forces, we are focusing only on northwestern parts of it, as the self-administration consider this file as something related to ownership of them, and that they need to control its aspect as much as possible. Jumping to COVID situation in Syria, it was introduced in the governmental health areas early in between February and March, due to some travelers from Iran and from Iraq, but no cases were reported in northeast nor in northwest. And this was something that everyone was stressing about, why there are no cases, how can we do that? And then northeast had the virus introduced to it. Unlike with northwest, where we started the preparation with upgrading the lab and doing some capacity building training for surveillance aspects and for lab testing at the beginning with limited resources. Of course, at that time, with only one lab, with one PCR machine and one person who can run it and do the test. And we had to wait until almost July to have the first confirmed case in northwest Syria. And as you can see, the cases started slowly but steadily, and then we noted the peak between end of October and till the beginning of December. Unfortunately, we are having just one area to share the data from, but the picture is not much different when we look at the other regions where we have information shared through whole of Syria approach and other initiatives. And as you can see from the epi curve, it's the classical one for an outbreak that no one did any kind of intervention or proper intervention to it. With slow start, a peak, and then the resolve. And recently, we started to see an increase in the number of reported cases also. But overall, the positivity rate was high in general, and especially at the time between October and December, and then started to decrease a little by little. With more than 22,000 confirmed cases, one would expect that we will have more, but again, it's related to the capacity of the lab to perform in the field and the notified cases also. Because of the political situation, we had to segregate the information that we share with others between the Peace Spring area that I mentioned in northeast Syria, this small place with small number of population, yet they are having more than 50% of positivity rate on a daily basis at the moment from the cases that we are detecting. Just to respond to this outbreak, and because we have no proper governance structure in the Northwest, WHO took the lead in a way under the health cluster lead and created a task force with different partners from the NGOs acting in that area to perform the activities related to the prevention measures and then to the case management if needed, and the recovery following this. And I must say it was not easy because you are obliged to bring multiple actors, 10 more of them, into one table, and you have to coordinate all those efforts into one direction. From our side in A1, we focus on what we do, on surveillance and on lab, and we managed through time to expand our capacity from one lab, one device, and now we are having 6 labs in different areas. 5 of them are in Northwest, and we are collaborating with a lab supported by one of the NGOs to run the test in the field. And this is an exercise that we were more than happy to do because we helped in enhancing the capacity and building it for other partners to be able to run the test and to conduct the activities in that. And this is one of the objectives that we have in our program, to have a public health capacity within the partners in the field. We hope that no more cases will be reported and we can make use of the opportunities that we have, but unfortunately, we started noticing in the last few days that more cases are reported. The coordination efforts in the field were not easy, but we tried to do our best with the partners to have a proper approach via pillars, different pillars, from case management to risk communication with the community and with the healthcare providers, up to the level of reaching the vaccination that start to enroll since the beginning of May. It's a slow start because of Ramadan and the holiday and hesitancy from the healthcare providers to be vaccinated, but we hope that we will see an increase in the number of people who are vaccinated in the field. I must say that the main challenge that one of the main challenges that we are facing is the context itself. Any kind of escalation in the military offenses would lead to massive number of displaced population. And this is something that no humanitarian in the field would love to see. We recall that at the end of 2019, beginning of 2020, an escalation of the military offenses at southern Idlib. In this area, close to a very strategic highway, led to the displacement of more than 1 million civilians from that area. The majority of them had to be concentrated in the camps area as usual. And it's not an easy task for anyone to try to implement surveillance activities or any other of public health related initiatives in this context, with the non-regular camps spreading all over the place. The coordination between the partners is a challenge, the absence of governance and having to create your own governance system and portfolio in the area is very critical for all the partners. The need to get permissions to move your specimens from area to area, and lockdowns that happened in some areas. Although we are not working in COVID properly in Northeast Syria, but we are covering the other surveyed syndromes, like the ones related to suspected measles, to meningitis, waterborne diseases, and so on. And during the lockdown periods in Northeast Syria, it's almost impossible if you do not have permission to move around to conduct any kind of verification or investigation in the field. Overall, from those challenges, we try to look to the opportunities. The window that we had with a minimum number of cases was a golden opportunity for us to start the implementation of the vaccination activities. It started, as I mentioned, at the beginning of May with the healthcare providers and other humanitarian and healthcare workers. And the plan now is to include the elderlies with comorbidities as soon as possible. And hopefully the efforts will succeed in providing the proper immunity to the community there. This is just a brief about the situation, and I look forward to hear your questions. Thank you, Dr. Kaveh, one more time for this opportunity.
Thank you so much, Dr. Naser, for sharing your perspective, but also the amazing work that you're doing. You know, when we teach public health surveillance to our students at the Yale School of Public Health, we always talk about government, that is government's duty and responsibility to do surveillance of disease. And the fact that you and your colleagues as a nonprofit organization are doing public health surveillance is just remarkable. And to my knowledge, there's not a whole lot of information, knowledge, expertise out there. So you are teaching us a lot. I'm going to turn it over to now Dr. Maryam Babrek, who's a lecturer in global and international public health at University of Leeds in UK. Dr. Maryam has over 2 decades of experience teaching, doing research and consultancy, and in 8 low middle income countries, including Yemen. And today she will be sharing with us her perspective on how COVID has been impacting Yemen. Dr. Maryam?
Thank you very much for having me in this conversation. And let me first share my screen. Do you see the screen now?
Yes, we do.
Yes, so let me start with saying that Yemen shares a lot of what Dr. Naser mentioned. Yemen started the conflict and the unstable condition formally in 2013. And since then, Yemen faced a lot of problems. So if you look at the picture behind me, this is what Yemen looks like before the conflict started. But now, if you look at the screen, the picture I'm having in the first slide, Yemen had a lot of people who've been displaced from one place to another. So many of them have left this beautiful building, which has been over years and years a character in the Middle East, to live in these camps, in these tents. And many of them, they don't even have the leisure to have such a tent to live in. Many of them, they live outside, no shelter, no place to live in. And this is just a picture of one among many thousands families. They don't have even the leisure to have a camp to live in. You see the child is living on the floor, there is no access to water, and then you can imagine how difficult it is to ask people to keep social distancing, washing hands, and all the precaution that we encourage everyone else to protect himself or his people against COVID. Also, there is a lot of accumulation of rubbish, and that also contributed into spreading of so many infectious diseases in addition to COVID. For example, malaria, when it's raining, there was a lot of infectious diseases and outbreak spread. And at the same time, because those measures that prevent people from COVID-19 were not in place, what happened is hospitals were full of cases. So you can see the limited number of intensive care unit has been occupied. And this is a picture I took it, one of my colleagues took it from one of the isolation unit in one of the governorates. So you can see COVID patient is being thrown on the road outside the intensive outside the isolation unit, no space for them, and that's caused into many people were graved in one day, and this number can go up to 150 cases per day in some of the governorate. That's what the governorate that announced that COVID cases exist. Many other governorate, they don't announce, we don't know what's going on there because of several reasons I'm going to mention. So this is the context I'm going to talk about. I have so many things to mention, but I will try to be very, very brief about the situation. So just to start with, so far, there are formally only 6,000 cases or 6,500 cases of COVID being confirmed or reported officially by the government. And the case fatality rate is 20%, almost 20%. However, that doesn't reflect the situation in Yemen because one of the survey that the WHO has done in Yemen, which represent representative sample of the population, showed that I think I'm going to hide the slides a little bit so you can see the numbers here. It shows that 27% of the population had COVID at some point. This is among the people who are survived after a couple of months after the first wave. And that's because of so many other reasons. I mean, the low reported cases of COVID-19 because of so many other reasons. One important reason is there is only 10 lab able to diagnose COVID-19 across the country that covered 30 million population. Only four, those are the 10 lab are public lab, in addition to 4 others private, and that's definitely not enough to cover the diagnosis of COVID-19. In addition to other challenges like stigma, and people are afraid if they go to the hospitals, there will be no space, they might get infection more and more. There is also a lot of uncertainty among healthcare workers who are not trained to deal with viral infection before, because Yemen over years and years used to deal with infectious disease like bacterial infection, malaria, and other things. This is the first time that Yemen is facing epidemic caused by viral infection. So people are not prepared, either the lab, either the people, even the orientation. When you tell people about viral infection, they think it's only influenza and common cold that you would catch during the winter. Nobody even faced the situation when viral infection was really serious and causing death. When we come to where those 6,500 cases reported, they were only reported from 3 governorates, which are under the control of the legal government, while the rest of the country, which covers 70% of the population, no reporting at all. In the first wave, the no reporting was because people didn't know how to diagnose COVID, lab problems, and so on. But in the second wave, in addition to all those challenges, the government, I'm talking about Yemen has 2 government. So the government in the have a authority over 70% of the population, intended not to report COVID-19. They assume there is no COVID in Yemen, and then you can imagine the rest of the situation. No one among our colleagues, I know many of them, they work in the Ministry of Health, they are not able to tell us formally about the cases of COVID. However, we knew among my colleagues, there are 160 doctors lost their life in those governorate because of COVID. So this is to add to the challenges that the country is facing in order to report COVID. But based on the cases that we have so far, we knew that Yemen faced the first wave between April last year and ended. That wave ended almost the beginning of September, and then we started to have another wave starting from February, and it's still in place now. To deal with COVID, it's really sad to know that Yemen, the whole country, only has 48 intensive care units, which is not enough to cover the cases. And that's the reason why you have seen in the first slide that people are outside health facilities, no space for them. So that was even after the big improvement that the WHO had done in the country in preparation for the second wave. I'm not going to talk about all the details about Yemen because you can go to this dashboard, which is a WHO available on the WHO website. They will tell you more about the lab, the other diseases that have been diagnosed during the first and the second wave. But I will just pick some of those important things which highlight the risk and the unpreparedness of the country to deal with such epidemic. So the WHO, after assessing the condition in Yemen, they say they would need 142 million US dollar in order to just try to provide the basics to help the country overcoming the problem. But their problem is 87% of this fund is not available. So there is a big funding gap. And I'm not going to go into the details of that, but happy to answer all questions about which gap need to be filled first. So in terms of theory, the WHO learned from the lesson in the first wave and came to with a plan for COVID-19 in Yemen that covered 10 pillars. One important one, the first one, which is the most important one, is to have coordination between the two governorate, the internal and external initiative in order to increase the ability and the capacity of the country to overcome this problem. Then we have also the risk communication and community engagement one, because we realize that without community engagement, you can't really deal with the situation in such limited, poor governorate, fragile system, and also when people deny and have stigma and they refuse whatever you are providing to them. There is also a big pillar on surveillance, either to improve the surveillance system which is in place, but also to have this study that I mentioned earlier, the WHO implemented in order to estimate roughly what's the prevalence of COVID-19, because people totally deny that this is COVID. So when the evidence came that around 1/4 of the population had COVID or had some response to COVID, then at least healthcare workers realized that it is a problem, it is there. Yemen is not excluded from COVID. Also, they have a pillar on point entry, but unfortunately they have zero fund for that. So Yemen had recently reported cases of the Indian version because there is no control of the point that anyone can enter Yemen, you can go outside Yemen, and that's can let us expect that Yemen might be facing a big problem if we don't control the point of entry. There is also a pillar to improve the lab capacity, intensive care unit, in infection prevention control, case management, supply and logistics, and others. The last pillar, which is vaccine. The vaccine has arrived Yemen at the end of March. The first campaign started in April, on the 20th of April, but there is a lot of challenges. I'm going to mention just only a few challenges. The one big challenge that we face as initiative and the government is facing, and I think the whole world is going to be challenged by that, is the government, which covers 70% of the population, initially totally refused to get the vaccine allowed in 3/4 of the governorates. Then that's the time when we stepped in as initiative. I did work in Yemen for years. I worked for the Ministry of Health with the NGOs, with the World Bank, with the UNICEF, even the USAID. So we try to use our network inside Yemen to informally encourage healthcare workers to have advocacy, internal advocacy, advocate for their right to get the vaccine accessible to them. We also liaised with the WHO and the external media to have external advocacy as well, to help in making the vaccine accessible to the countries. Thanks God, in the last few days, we received a very good news that the government in the other government, the non-formal government, and I'm trying to avoid using terms because I really play an important role in, trying to get the two working well for the benefit of the population. So the government, I'm talking about Ministry of Health, has accepted to get the vaccine approaching Sana'a and other governorate and make it available to the healthcare workers. However, they challenge us by saying we are not going to do any campaign to encourage people to get it. We were happy to take that leadership, and we said, yes, we are going to lead the education campaign for healthcare workers and the community, the elderly and people who have comorbidity. And I'm going to let you know what we have done so far in the next few slides. The other big challenge that face vaccination in Yemen is, yes, the COVAX has provided Yemen with 20% of the doses. However, there is no operation cost covered at all. So in such a poor country, you would need $3 US per person to make that vaccine accessible to people. That include training, including outreach activities, taking the vaccine to people who live in under very difficult, unstable condition. So there is no fund for that. So the way that the government is doing the vaccine at the moment is they only run it over a week. So they really, in order to make better use of this vaccine, they really need people who are keen to get the vaccine. So once you get the vaccine in the government, in the governorate, then they take it. But actually, that's not the case. Many people still hesitant to take the vaccine. You don't have operation costs, so it's really very, very challenging. So just to give you an idea how much Yemen have achieved in terms of the vaccination uptake, out of the 3,600 doses that arrived in Yemen, over a month now and a half, only 18,000 people have got the vaccine. So if we don't accelerate the action and encourage people to get the vaccine, maybe the rest of those 300,000 doses will be expired in operation. There is only 2 months and a half before the expiry date of those. We are trying to do our best as initiative, but it's really, really very challenging to work under this condition. Just to give you an idea, out of those 10 pillars, there is no fund available for any of those pillars. So the gap is 100% for the first 3, the 6, the 9th pillar. The only one which Yemen had fund for it is actually the case management, which was based on the collaboration between colleagues in Germany and colleagues in Yemen. There is an association committee that work with the government in Germany who did manage to help training people online, getting the guideline, but also provide some intensive care unit. So this is based on initiative, and I would emphasize what Dr. Kaveh said earlier, in such humanitarian setting, you really need to involve everyone. Community and initiative does play an important role when the government cannot do too much. Just to, I'm going to move a little bit faster. So what happened so far, because of this difficult condition, you see many people are graved in the same time, but that also, even though it's a challenge, it also wake up the community to say, well, you are facing a big problem here, denying the condition, it's not going to help. So as I said earlier, we have lost during the first and second wave around 164 doctors. Bear in mind that Yemen in 2004 had only 3 doctors that would cover 10,000 people in the population. After the war in 2013, I would say 3/4 of them traveled outside the country to work in different countries, including the Gulf. So if we would say Yemen at the beginning of the war had only 1 doctor per 10,000 people, and we keep losing this large number of people, you can imagine how bad the situation would be. Not only in control COVID, control malaria, and in malnutrition, and many, many other problems that the Yemen is facing. So that's why we were keen to have the vaccination accessible to the health staff as early as possible. COVID also created a lot of opportunities for Yemen to work. So for example, I left Yemen in 2009. I did not have a lot of connection and work in Yemen, but COVID-19 made me worry about my friends, my relatives in Yemen. So I started to reconnect with Yemen and colleagues. And I'm just one example of many, many people who live outside Yemen, and they had very good input inside Yemen. So for example, the initiative that started to doing a lot of awareness campaign. Unfortunately, I have to say that many of those awareness campaigns were copied from Saudi Arabia, for example. People are doing in Qatar, and they used in Yemen, which doesn't work perfect. You need people who would adapt those materials to the local context. We try our best, but we don't have budget, we don't have time. It's all voluntarily work, so it's not efficient, but it's much better than nothing. The other thing is we did work very well. I'm not talking about myself, I'm talking about many other initiatives to build capacity of healthcare workers. We had, for example, the Yemeni Doctors in the Diaspora is just an organization established in May as a response to COVID-19. They run a lot of seminars, workshops, open discussion, live discussion with people. There is also Interim, which is a UK-based NGO. They are running conferences after conferences. One on public health was about infection. There is also other colleagues who did work in Yemen many years ago. Dr. Miqdad, who is in charge of Washington University, he ran a couple of sessions in Yemen. So that's what the initiative is doing, try to do their best in terms of capacity building. There is also donation that, for example, I talked earlier about the German Yemeni Association, which they equipped Yemen with a lot of intensive care unit and oxygen filling. There is also the vaccine, which we played a lot of role in making internal and external advocacy. That's really something we're really proud of, and I wish to write about this. It is very effective, and sometimes the people who are external might play a better role than people who are part of this conflict. So just to mention, one of the main problems that we face in Yemen in surveillance are very similar to what Dr. Naser mentioned earlier. So for example, the health staff themselves are only few who are dealing with the surveillance. You can imagine there are 2 people covering half million of the population in terms of coverage. They are not protected themselves. So many of them, they got the infection during the surveillance for COVID-19. They don't have personal protective equipment. They have to buy it themselves. There is no insurance, but also other epidemic outbreak were there. There were poor transportation. If you know, Yemen is a mountain country that you might need to travel for hours and hours in order to reach one village to get the vaccine done and surveillance and so on. But people also don't have transportation. They don't have money to cover the transportation. The issue of stigma is a big problem in Yemen, that many people, they hide their COVID-19 symptoms, including my colleagues, the healthcare workers, because the second wave, it's very similar to the context of many other poor countries, where in the first wave, it was if you are recognized as COVID-19 case, the police would would come and catch you, and then, you know, they want to take you by force into isolation units. So that's really made people afraid to report the cases. Many people are, even among healthcare workers, they would see if I would report it's COVID cases, that people would put the blame on me, that I'm not taking precaution. And so it's really so complex. But I would emphasize what Dr. Naser mentioned. It's very similar context. There is weak registration, delay notification, in addition to the political deny of COVID-19 in many governorates. The other challenges that Yemen faced, the hospital capacity is really very limited. We were not prepared for viral infection. As I said, there were poor training for health staff. There was no national protocol. We did our best as initiative to update the Ministry of Health, both in the south and the north, with the national protocol. They were listening in the first wave, but then the second wave, they realized there are a lot of medication that I would find in the UK, it's not available for them. So these kind of challenges that we face. Also at the beginning of the second wave, at the end of the second wave, we have also dengue fever, cholera, measles, and many other problems happened at the same time. And because of the lab capacity is really limited, we were not able to differentiate, you know, all of them come with fever, cough, chest infection, and then death. So it was really hard with no lab technician, good lab to differentiate what are the causes. There was no case tracing at all. The lockdown was impossible because people, they are working on daily basis and they give their income on daily basis, in addition to the denial and many other conditions. So again, for the vaccine, there was a lot of problems with no operational cost. There is a lot of rumor, anti-vaccination campaign in the social media. So we try to identify all those challenges and identified what we could do as initiative. And I would say I'm really very proud that I did allocate a lot of time, try to coordinate between initiatives, different initiatives, to do something. And just to give you an example of what we did all together as initiative, we worked with the university in Hadramaut to try to understand how many people are willing to take the vaccine if the vaccine arrived. And that was before the vaccine arrived Yemen. So we realized 75% of the people and 74% of the healthcare worker would refuse to take the vaccine. So we investigated what are the reasons not to take the vaccine. We identified list of rumors and misinformation that they are reasons for them to reject the vaccine. And then we have developed video, video recorded messages, try to ask the question and then answer the questions for 25 rumors. These were in Arabic from different colleagues in different countries from different specialties. We also share our experience of having the same COVID vaccine, AstraZeneca, which is available in Yemen. We assured them this is what happened to me in the first day, second day, and third day. So they are assured that it's okay to take the vaccine. I can share with you the video if you want. It was very short, very concise, replying to 25 rumors around COVID, and that was done by 3 major initiatives. One is in the south, one covering the whole country, and one was UK-based people who are originally from Yemen or are interested in Yemen. So I'm very proud that I did coordinate that work. It wasn't easy to work with people from different background, different interest, and try to convey the message. But I would say when we posted this, we posted in the media, in the TV, in the radio programs, we received many requests for people to have open discussion about the vaccine, and over a month we had the number increased, and the government in the legal government did ask us to continue with this work. So they really feel, and that's presented by the minister himself, who said he really wants us to carry on that to avoid having the vaccine expired in the storage of the UNICEF. So that's briefly the situation of Yemen. We try to do our best. It is very, very, very challenging, but it is another example where community can work, initiative can work. Of course, we will not do what the government should do, but we try to communicate what we have achieved through seminars like these to get more help and support for Yemen, but also to convey the message in humanitarian setting. Sometimes the formal channel, they are not the only solution. You have to have informal channels and collaboration with other people. Thank you very much for having me.
Thank you so much, Dr. Maryam. It's remarkable what you've managed to do, even though you're now in UK. But I guess one silver lining about this pandemic has been we're all learning that we could have really meaningful impact doing work remotely. Some of the things you mentioned, all sorts of training, capacity building, capacity strengthening. So we don't necessarily have to travel to the country. There's plenty that we can do. And I'm hoping that the work that you shared with us will inspire others to think about how they can step up and collaborate and partner with countries that are going through humanitarian crises as well as COVID. So thank you for that. I will now turn it over to Dr. Leslie Gross-Wyrtzen, who's a postdoctoral associate with the Council for African Studies. Her work focuses on, at Yale University, her work focuses on the relationship between borders, race, and political economy between Africa and Europe. Her first book project, entitled Bordering Blackness, the Production of Race in the Morocco European Union Immigration Regime, draws on 11 months of ethnographic research among West and Central African migrants moving through or contained within Morocco, and was funded by a National Science Foundation Graduate Research Fellowship and a Fulbright Hays Doctoral Dissertation Research Abroad Fellowship. Dr. Leslie, I'll turn it over to you.
Great, thank you. It's just a real honor to join this panel. I'm just struck by not only the amazing research and scholarship of, but as you pointed out, Dr. Kaveh, the real work that's happening on the ground and the collaborations that are happening among these amazing panelists, that is really inspiring for me. So I think I'm in some ways the odd one out here as a non-medical professional, and also as someone that's working on the edges perhaps of a humanitarian context, or for perhaps thinking about a humanitarian context over a longer durée and in a slower mode. So as an ethnographer, my goal today, I guess, is just to provide a small report from the field that will give you a sense of some of the politics of immigration, public health, and humanitarianism in this moment. So I want to just give you a little context for the case that I'm addressing that looks at the impacts of COVID-19 on West and Central African migrants and refugees who are in Morocco or moving from their home countries through North Africa and onto Europe. And Morocco, along with its fellow Maghrebi countries, participates in the European Union's externalized border program, which basically aims to keep migrants and refugees from reaching European territories by stopping them well before they reach those territories, or even pursuing them along their migratory routes as they move from south to north, or in the case of some Syrian refugees, from east to west. So a central facet of this transnational Mediterranean border zone is a policy of pushback, which is a militarized campaign that intercepts these migratory people, especially in the Mediterranean Sea, and pushes them back to countries in North Africa. And I think most famously, we've all read the reports of people at sea being returned by Italian Coast Guard, in particular to Libya, where they've been in really, dire conditions. So this policy of pushback, of intercepting people at sea and pushing them back toward the North African coast, has led to 20,000 or more people dying since 2014 and has resulted in larger populations of migrants and refugees who are living quite precariously across North Africa. A lot of these people are not confined, as we might think traditionally, in a refugee camp, but instead perpetually experience what one researcher, Martina Tazzioli, has called containment through mobility. So migrants they're moving from place to place to try to subsist in North Africa, or because they keep being forcibly displaced from where they're staying by police or border guards. So I think of border geographies in Morocco and the region as a humanitarian context, primarily because I'm thinking not about open war, but instead about the coupling of the militarization of border enforcement in the region with the informalization of migration management. So that really has to do with, not using camps and informalizing or devolving the care of migrants and refugees to just local people, to migrants themselves and their networks, and then to patchwork, often uncoordinated work among local and international NGOs. So that's kind of the broad context. And prior to COVID-19, Morocco in some ways has been a success story. The bulk of migrants and refugees are, as I said, are from West and Central Africa. And due to pressure primarily from international and local human rights organizations, as well as migrant activists, in 2014, Morocco offered exceptional residency permits to 55,000 people who were living in the country without status, which was aimed at bettering their condition, helping them find stable housing and work and the like. And in addition, the Moroccan government extended social services to undocumented people in the country, which included healthcare. And one of the targets of this at the time was to fight tuberculosis. And Morocco has a really robust tuberculosis control and surveillance apparatus with public health that has been quite successful in the country, both with its citizens and with its migrant populations. So this sort of humanitarian turn in bringing migrants in and incorporating them into, social services was aimed at serving as a model for other countries in Southern and Eastern Mediterranean. But on the ground, as we find in my ethnographic work, migrants' access to these services, and particularly healthcare, has been limited. And this is partly due to the fact that the Moroccan public health system isn't adequate to meet the needs of even its marginalized citizens, let alone migrants. But it's also, in particular for this population, a product of anti-immigrant and racist practices that are leading to migrants being refused admission to hospitals for treatment. They're being denied referrals for specialist care. They're also exposed to more violence by both state agents and civilians. So much of the healthcare provisioning for migrants prior to COVID-19 was facilitated by NGOs who are prohibited in Morocco from providing healthcare, but they can offer facilitation between migrants and healthcare professionals or administrators. And they also will, on a case-by-case basis, fund laboratory work, which is not covered under the extension of healthcare access, procedures, and medicines. So what happens is the medical care prior to COVID-19 with migrants is really ad hoc and relational, based on who they know and what networks they can access to be able to get healthcare. And that, coupled with migrants' unstable housing and their continued sort of forced mobility within the country as they search for means of subsistence, means in particular that chronic diseases go untreated or undertreated. And in addition, many younger, especially men, migrants live outdoors in camps and face health conditions related to stress or lack of hygiene in spaces with no bathrooms or running water, and diseases associated with that as well. And then, as I mentioned before, migrants were often refused treatment or unable to navigate the system, maybe because of language barriers, misinformation on the part of the hospital administrator about their duty to care, and then also because of these racial and anti-immigrant bias. So since COVID-19, I've been in close conversation with several interlocutors there. I've been in the US and unable to return to Morocco, but I have a close research partner, Freddie Malingi, who is a Cameroonian former migrant and now NGO worker, community leader, and researcher. And so we've been in a lot of conversation and taking notes, and we're co-authoring a paper together on this specific moment and what's happening with migrants around COVID-19 and the Moroccan response. So Morocco responded to COVID-19 very rapidly, more rapidly than the US, which is where I am, to contain the outbreak. They initiated very strict quarantines and imposed a total ban on travel in or out of the country for 100 days. And they also proactively ordered vaccines. And so this response, which was really securitized, was successful in slowing the spread of COVID, at least in the first wave, but it wrought other, deleterious effects on Moroccans and migrants alike. Many of whom, up to 40% of the Moroccan population, works in the informal economy. And so they rely on day labor, street vending, or especially in the case of migrants, begging on the streets. So for the first 100 days or so, police were widely dispersed across the country, and especially in urban spaces, to prevent people from leaving their homes. And cases of violence were documented against those who tried to defy the quarantine. And especially for migrants, this securitized response, plus heightened fear or prejudice about Black migrants, has made them more vulnerable, not only to COVID, but again, to these other health conditions, food and housing insecurity, violence by various agents, and then also is ultimately resulted in more dangerous attempts at migrating across the Mediterranean Sea or the Atlantic Passage to the Canary Islands. So just really quickly, I want to talk about the impacts of quarantine on the two communities that I worked with in Fez and Meknes, which are two urban centers located kind of in the center or interior of Morocco. And so for many of them, for many migrants, quarantine meant that you had to choose between abiding by, the rules and having no food, or leaving your home to try to find work. And that would often result in, the police finding them, imprisoning them, or deporting them. And one example from one of my interlocutors was during this period, he broke a quarantine to beg for money because he didn't have any food, and was stopped by police who demanded that he pay an immediate 300 dirham fine for violating the quarantine rules. So that's about $30 US. So he couldn't pay that fine, and he was immediately expelled from the city to the border with Algeria. And that sort of process has been documented and been fairly common, at least among the folks that I've been talking to and working with. And, the lockdown has also led to the evacuation of outdoor camps. And because of lack of space, they've been confining a lot of the people who were staying in outdoor camps into psychiatric hospitals or into prisons, where there has been a tremendous outbreak within some of those prisons, particularly in the city of Wyrtzen. And also COVID positive migrants, when one member of the community or multiple members of the community test positive, there have been cases where Moroccan authorities rounded everybody up and forcibly detained and confined them to school buildings or other facilities, often without providing for their food or their healthcare, during the 2-week quarantine period. So this policing of people's movements made it really difficult for people who didn't have documentation to survive on a daily basis, but also made access to regular treatment for chronic conditions really difficult, in particular dialysis and some treatments related, getting insulin and things like that for diabetes. And women in particular in migrant communities have reported increased domestic violence as they're trapped in often overcrowding housing where the majority of the residents of the house would be men. And then finally, just briefly to talk a little bit about sort of the race-specific or anti-immigrant specific nature of the impact of COVID-19 and then the authorities' attempts to control it. The first, on the cover of one of the weeklies in Morocco, the Maroc Reporter, on the week that there was the first documented case of COVID-19, the picture showed the cover of the magazine showed a picture of a hoodie wearing Black man, when in fact the first documented case was a non-Black Moroccan who had just returned from Italy. So there early on was this sort of racial bias and this anti-immigrant bias as bringing the disease into the country that resulted in a lot of stigma and also in some cases, violence on the street. And that is, interestingly, my interlocutors are telling me, has really transformed in the last few months to instead a belief that Black Africans don't get COVID. And so not only are migrants themselves believing that and not trying to access testing and also the vaccine, but they're also in some cases being denied the vaccine. And Freddie Malingi, my partner, who does a lot of this healthcare facilitation, said that in the Fez community that he works with, which is several hundred migrants, he doesn't know anyone who's been able to access the vaccine so far. And some of that, again, speaks to the fact that Morocco is having a hard time getting access to enough vaccines, but also not prioritizing these more vulnerable populations. So the humanitarian, so a lot of the things that are happening in Morocco, I think, are resonant with a lot of other places, including Syria and Yemen that we just heard about, but also the United States and countries in Europe. But I think something that's really specific to the Moroccan case is that this experience for many of these migrants and refugees has pushed a lot more people to take greater and greater risks to try to get to Europe. And so the number of people who have died en route, either in the Saharan Desert or on the Mediterranean Sea or in the Atlantic Sea, has grown exponentially, while at the same time, a lot of the European navies are refusing to rescue in some cases because of fear of the virus or because they're already overtaxed in some way. So the situation has become a lot more dangerous at the same time that more and more people are being driven into it. And so that's kind of where the Moroccan case stands right now. And I think that resonates with a lot of, with Tunisia, Libya, and Algeria as well.
Thank you so much, Dr. Leslie. We've learned a ton from you as a public health person. I always think anthropologists have so much insights to offer for public health interventions, and your presentation was a great example of that. We had invited Dr. Deko Mohammed from Somalia to join us as well, but unfortunately I don't see her. She may have had some difficulty joining us. We've completed our 3 presentation. Please send us your questions. Maybe I'll get started with a couple of questions, and then I see at least one question in the chat box. Dr. Naser, I want to start with you. I'm very happy to hear that vaccination in northern Syria, which is not under government control, has begun in early May, as I think you mentioned. Can you give us a sense of, first of all, what vaccines are actually available? And vaccine hesitancy has come up a couple of times. Do we know much about vaccine hesitancy in northwest of Syria, and what is the nature of the hesitancy, and what can be done about it?
Yeah, we're lucky that we got the vaccine eventually, and it's as in Yemen through COVAX initiative. It's AstraZeneca, which is good, but at the same time it's a problem and an issue. And with the COVAX initiative, the first targeted group are the healthcare providers and the healthcare workers and the humanitarian workers in general. And then you go to elderly with comorbidities and so on. And it's only 20% of the population. And that's it. And as Dr. Maryam mentioned, it's just the vaccine and no running costs. So from the beginning, the first issue that happened is that the vaccine started during Ramadan period, and people started to say that, okay, if I take the vaccine, I may have to not fast on that day, and I don't want to do it after Ramadan. So please let's postpone it till after the holidays. And the other thing is that with the rumors and the information about AstraZeneca and the coagulation incidents that happened and severe adverse events, it also caused a problem, especially with your first group to target are healthcare providers, which are the most difficult people to convince with any kind of medical intervention, ourselves included, of course. I think that our colleagues in the vaccination group tried their best to implement as much as possible. And one of the activities that they did is having the approach of going to the health facility instead of waiting for people to come to them. So they have more than 90 teams spread all over the accessible areas for them. And they have a schedule to visit the health facilities and vaccinate the healthcare providers who are willing to be vaccinated. Still, the numbers, I believe, were a little bit low. We received more than 50,000 doses just before the beginning of May, which will be used. And so far, the numbers are around 6,000 to 7,000 people who were vaccinated, which is a little less than expected, but we are seeing an improvement in recent day after the end of the holiday. I must admit, it's not an easy job to do when it comes to implement a vaccination campaign, especially with a vaccine that doesn't have a big number of evidence-based information that you can rely on to convince people. On the other side, in northeast Syria, they received some amounts of vaccines, not big amounts, of course. And the feedback that I received from the field is that it's the one manufactured in China, and it was delivered through the Ministry of Health from Damascus. So they didn't get the AstraZeneca one, and yet it's fixed centers and the people willingness to be vaccinated is not as high as possible, unfortunately.
Okay, thank you so much. Dr. Maryam, I see a question for you in the chat box. Asking you if you could please summarize and recap or elaborate challenges specific to cooperation and non-cooperation between the recognized government and the authorities in Sana'a concerning COVID-19, and how specifically the division and war in Yemen affects the struggle against COVID-19. Big question for you.
Yeah, it's a big question, and I think what we have seen, it's not only the government. The division and the poor coordination was at all levels. It was at the government level, it was the initiative level, it was also at the community level. So maybe giving the example would make it much easier to understand. The main problem at the government level is there was a government internationally recognized, and that's based in the south of Yemen, in Aden. And there was another government which recognized themselves as a government, but they are not recognized internationally. Now, when it comes to COVID-19, two issues were really made COVID-19 control difficult, and I would say the first is reporting of cases, surveillance. So when you have a case reported in Sana'a, for example, you have to notify and report that to the WHO. So in order to reach the WHO country office and then regional office, and then globally, you have to go through the internationally recognized government. So then that made the government in Sana'a to say, no, we don't have COVID-19, because they don't want to report it. They don't want to say they are under the control of the government in Aden. And that's exaggerate the hiding of the condition in 70% of about 70% of the population, under-reporting of cases. Maybe in the first wave, everybody was scared, so they were okay reporting some cases, but those reported cases never exceeded one death case came from Sana'a. So that's one thing. And then you can imagine the rest. If you don't report cases, then the rest would be a problem. Then the second problem came when the vaccine came. So you get the vaccine from COVAX, it has to go to the WHO and the UNICEF, and those two organizations deal with the internationally recognized government in Aden. So all the vaccine doses arrived into Aden. In order to get them reaching the rest of the country, you have to deal with the officially recognized government. At the same, because they don't want that to take place, they refuse to take the vaccine, and then that made the job very, very difficult. In order to overcome both problems, the surveillance and the vaccine, we failed. We failed to make the Ministry of Health in Sana'a reporting the cases. We were just collecting the cases informally, trying to get our own database, at least among the healthcare workers, among the highly educated people, the influential people. So we have some informal record about who had not infected, who passed away because of COVID-19. When it comes to the vaccine, we try to push and use our good relationship with colleagues and people inside. And as I said, at the end of the day, we did manage to get the vaccine accepted. They still haven't started the vaccination yet, but they put a lot of challenge in our side. We have to do the education campaign, so which is not easy. And these two examples, I can give you more example. For example, the guideline, when we work with the government to develop a guideline based on our knowledge of what is available, the facilities available in Yemen, we started with the official government, assuming that the other government will take from them, but they totally refused. They said, you made that for the for the ministry in Aden, so you either have to develop another guideline. So then you started to see the Yemen has so many guidelines, one coming from Germany, the other one coming from Saudi Arabia, and so we just want to help, and there is no coordination. And that's why in the plan for the WHO, pillar number one is to get this coordination in place, but because there is no fund, maybe sometimes in conflict setting, if you pay people, they might, try to sit and have some conversation about how things could work. But if you don't have budget, that it was very difficult. The other thing which I would say, I did not even expect that poor coordination to be at the initiative level themselves. So just an example of having these education videos done by the three initiatives, I faced a lot of challenges that many people want to pull me in their side, but I said, well, if I represent people in the South, I do care about my friends in the North, and I had a lot of time negotiating and trying to explain, I don't belong to any party, I belong to the humanity, I do care about everyone counts. But to get that message clearly understood by initiative, I had to pay a lot for that, and a lot of accusation, a lot of, verbal aggressive replies. But at the end of the day, I'm very happy that we did manage to do it. When they see the outcome, they are proud about, yes, you can do something to the whole country. But it is a real challenge because they've been in this division and poor coordination for now 9 years. So you cannot change that, even though, yes, COVID is a disaster and they understand to some extent. But when it comes to the reality, they feel, oh, I'm from the South, how I can speak to people, they are from different parties, they belong to this government. So you had to, sometimes you can easily lose the focus. It depends on who is more convincing than others, but it really needs many people to play that role. And I think I'm exhausted because of this. And now I can understand why Yemen had many people try to solve the conflict between Yemen and the same in Syria. They change them every couple of months or maybe 1 year, because it's really exhausting process. So these are the examples this came to my mind.
Thank you so much. I think COVID-19, as you're describing, has reminded us the political nature of public health, which frankly, we don't always teach our students, but we need to make sure they're aware public health is not just about the science, it's also about the politics. It matters a great deal, and they need training and preparation for that to be able to do the kind of amazing work you're doing. I just want to let the participants know that we can go as late as 1:30 US Northeast time. So we have about 13 minutes maximum that we can go. I see Dr. Leslie had a question for Dr. Naser. Do you want to just mention it?
Sure. And Dr. Maryam, you also you really addressed this too. And I'm curious for Dr. Naser, like, you know, what sorts of privacy concerns are there when you're trying to coordinate surveillance, you know, in sort of a non-governmental context with so many different actors and sort of authorities on the ground? How does that work?
Yeah, it's a huge challenge, and we've been facing this since the establishment of the program, unfortunately. Respecting the confidentiality between us and the patients, not to disseminate or share the names, this is a main priority for us in the field. But what we aim to do is to play on the strength of each organization working with us, coordinating with us, and with each local authority. So we have health directorates in some areas, we have Turkish-supported health facilities in others, you have different local councils, for example, in some areas. So we try to coordinate and share the needed information to a certain level with each and every one with them, and try not to make it all over the place. So for example, when it comes to contact tracing, we at the beginning, because of the lack of funds and all the fund related issues and the human resources also, we coordinated with one of the NGOs which had a huge network of community health workers to conduct this activity and this exercise for contact tracing. So we had focal points from several areas that we communicate with, and we tell them to commence this activities, and we ensure that no names are leaked, and it to be done discreetly. Same applies to the confirmed cases, where we as a part of the case management approach, and because we know that it's difficult, for example, for a person in a camp to ask him to isolate himself from the others, and simply the answer would be, we are 10 persons living in one tent, 3 by 4. Where would I isolate myself? So the approach from the task force was to create community-based isolation centers. So to ensure that those people are abiding to the regulations as much as we can. Of course, we cannot force everyone to go. We share the names with the health directorate, for example, or a specific local council, to ensure that those people are transferred to that area to be isolated or quarantined or whatever. It's not an easy task, but and it's a headache, because you need to communicate with tens of people on a daily basis. But we are trying our best, and the help of the task force and the health cluster also helps in facilitating the communication with the partners. I hope that I clarified a little bit of the issue.
Yeah, I think that gives a really like on the ground concrete way that you have to do it. And it does sound like communication is such a major, like communicating and mediating between stakeholders on both of these cases seem like such a huge task, you know?
Agree. And the thing is that from the beginning, and again, this is built on the practical experience from the field, everyone has his own agenda. Everyone is receiving support or fund or donation from a specific partner or a specific donor for a specific object. So we know that they need to follow up some rules and regulations for them, and we do not want to interfere with that, but we want to make use of whatever possibilities that we are encountering in the field to reach the end goal, which is the service itself.
Thank you so much. Yes, please, go ahead.
Can I add one important point? I think I was medical doctor by training, but at some point at my career, I decided to shift from clinical approach into public health approach, and then I shifted into global approach. What really made me think about, and I think it's a lesson that everyone learned about COVID-19, is improving the health status of population. It's not about you have the medication, you have the vaccine, and you can just give it to people. There are a lot of issues that raised and became very, very obvious in COVID cases. The political dimension of health, as you mentioned, who is giving COVAX, who is giving what vaccine to where, and but also the economic dimension of health, the financial dimension of health. Poor countries rely on donation from rich countries. They are only covered, the plan so far is to cover 20% of the population. What about the rest of the population? Can those countries really control COVID-19? This depends on the decision made by high-income countries, but also the WHO struggle to make the power balanced between different countries which have different agenda in different places. But equity, it's a big issue, either globally or at the country level. So I think one important message I keep sending to myself, to my student, to everyone who is working in public health, it is really important for us as public health people, but people who work and really want to improve the health situation of people, is to revisit our values. Because if you have a political interest or political party, you find yourself really struggling to, have that balance between what you believe in and what you should do in order to save the life of people. When I had to do this, the graduation, in the graduation party, you have to stand and say, I do this for the, I provide my services to the humanity. Really take that serious. I mean, my message to the undergraduate people, take that serious, take a moment to think carefully, what does that statement means? Because it does influence the rest of your life. There are many situations where you can face people from different ethnicity, from different religion, from different background from you. Do you still provide that service to them? Or you would find yourself in a situation where you say, oh, I do care about my people, I do care about my country, I do care about my group. So this is an important lesson that the whole world need to reflect on. We have seen many countries denying poor countries from specific intervention, many political parties denying the other from services. But at the end of the day, if we don't help each other, the whole world is not going to get rid of this COVID-19 epidemic.
Thank you so much for that. So we have a few minutes left. I wanted to just ask about, with COVID-19, there's a lot of conversation about the indirect impact. And the indirect impact varies from how it has diminished vaccination for, say, polio and measles in children, how it has taken a toll on chronic conditions, access to treatment for your diabetes, hypertension, cancer, to mental health issues. And then Dr. Leslie actually brought up a whole other issue, which is because of COVID-19, as you were saying, there are more migrants who are taking a risk going through the Mediterranean. They wanted to leave and go to Europe. And unfortunately, some of them are dying as a result of that. So I'm wondering if how much information is known about some of the indirect consequences of COVID pandemic in the settings in which you have worked. If each of you can say maybe just a few words about what's been going on in Syria and Yemen, and if Dr. Leslie can tell us about migrant workers in Morocco.
I may start with this one, others can gather the information. And yeah, this is one of the first things that we looked at. And my main file with acute flaccid paralysis surveillance was affected in a way or another with this as a part of the surveillance itself before going to the whole public health related issues. And the lockdowns, the need to close the private clinics at some periods of time, will make the people, if the kid is still just suffering from a slight limp, that will say, okay, let's wait a little before taking him to the physician, or let's see the closest nurse or any other healthcare provider around us to manage it within the small community. This delay in detecting the cases will lead to delay in the sample collection, and then the lab results and the following activities. If polio was discovered in this sample, the overload on the labs, the national labs and the global lab network in general, all the resources are heading towards COVID, which affects the detection and the lab isolates for other etiological viruses or bacteria, the economic consequences. And when talking to people about the need to wash their hands for a specific period of time, to follow the personal hygiene practices, the answer would be, provide me with water to drink first, and then I will go to do that. Or when you tell them to quarantine or isolate themselves, they will say, if I don't work on this day, my family will not eat. We want bread at least. So it's a very complicated issue, and the consequences are increasing day by day if you don't try to look into ways to mitigate this.
Thank you. Dr. Maryam?
Yeah, I can add to this. I think the WHO in the region has kindly did a very good survey, which is available on their website, specifically looking at the NCD, the impact of COVID on NCD services. So it can give you per country how many health facilities that were affected by COVID, how many health staff either infected by COVID, but also the resources that been shifted. You know, NCD control, it's not in the priority in many low-income countries. And shifting those limited resources that hardly were allocated for NCD control being shifted to COVID treatment that has a huge impact on COVID. So I would recommend that document. It does have very good picture of the impact on NCD. But I would say one indirect impact of COVID is actually caused by, the virus load is really important factor that increase the mortality of COVID-19. And because of the health staff, they were not protected. They don't have protective equipment. It's expensive. It was not even available. Some of them, they had to, do it with themselves. They don't know what's the criteria for doing it, what quality, what type of mask they need to have. That led into death of many healthcare workers. So looking at the number we have on people who died because of COVID-19, I mean, the healthcare workers, many of them, they were taking leads in NCD control. Many of them, they were academic in the universities. So the head of the community medicine department, the person who is teaching many generation about public health is not there anymore. The person who used to lead the surveillance system and TB control program, we've lost him over the COVID-19. The person who is leading the training of the public health training in the country also passed away. And because of the war condition over years, there were no good system in place to transfer the knowledge from those key people to others. And once you trained group of people, they travel outside the country. So I'm imagining the impact of losing those key healthcare providers on Yemen is we are going to run out of qualified people who can deal with the public health situation in Yemen. But also a big problem because of COVID-19, people, when they started questioning the vaccine in general, we had a lot of people rejecting measles vaccines, rejecting polio vaccine, while this was not in place before COVID-19. So the rumor against, or the fight against the vaccine was not only specific to COVID, it was about questioning questioning everything to do with the vaccine. So we had in Yemen few epidemic of measles, epidemic of other diseases that we thought the whole world is going to get rid of, like polio. In some places, they, instead of having the coverage of polio vaccine up to 99%, even during the war, now after COVID-19, this number is markedly reduced into 20%. And you know, this is at any point we would expect polio to emerge again in Yemen. But the good thing is people started to recognize that, and the WHO and the UNICEF working hard to go and increase the coverage. But then with the limited resources, with the splitting in the government, how much money and resources you would need in order to return that to the normal before COVID. It's very, very challenging.
Thank you so much. I see we are out of time. I want to sincerely thank all the three panelists for a remarkable presentation, sharing their insights. I know it was a bit overwhelming to hear all these challenges, but at the same time, you're all doing inspiring work. So I'm hoping that the audience benefited from learning from you and also seeing the work that you're doing. So thank you so much, and I wish you a good day. Take care.
Thank you.
Thank
Bye,
you.
everyone.
Take care. Bye.
Bye-bye.